Right. I'm going to speak on the abnormal Dopplers, CTG, and intrauterine resuscitation, what the anesthetist is. You may just ask me, why do we need to know? We have obstetricians as they would manage, and if they tell us, call us for a section, I'm going to go and administer the anesthesia. I don't agree with that. They need to have a clear understanding about the pathophysiology of pregnancy, the risk that the mother and the fetus is in, the outcomes depending on how they intervene, the drugs that they're going to use, how are they going to affect the mother or the fetus, so that there's a very clear communication between the obstetrician, the anesthetist, and the patient. Ultimately, the interest is you support the health of the pregnant woman and her fetus. This is a very nice study which tells you about a closed claims project where they have analyzed the claims for newborn brain injury database, and they have said about less than 30% only the anesthesia may have contributed. But in 50%, there is some delay by the anesthetist. This is alleged. In 17%, the mental condition was involved, and in 8%, poor communication. So probably we'll clear the air about it right now. Let us come to one case scenario. Second gravida, para 1, who's had a unilateral nephrectomy, has chronic hypertension, has superadded PE, and she gives history of an intrauterine fetal death at 26 weeks. So what does surveillance mean? We have to see what is the disease, what is the maternal risk factor, what is the progression of maternal disease. This is not the purview of my talk. What I would focus on is the physical evaluation of the fetus, understanding the clinical progression of the fetal disease so that you accurately perform and interpret all the surveillance tests. So at each visit that the patient comes, you will decide, do I deliver this fetus? Do I give her steroids? And when do I call her again? So when the fetus was evaluated, they found that the growth was on the 5th centile. This is the 5th, 50th. So the growth is much below the 5th centile. That means it's a growth-restricted fetus. And by definition, if the fetal weight is below the 3rd centile, we call it severe fetal growth restriction. And this fetus in utero is at a risk of chronic hypoxia, is under stress, initially may compensate, later goes into decompensation and death. So all your monitoring is focused at identifying this stress, compensation, decompensation, intervene before the compensation becomes decompensation, and thus ultimately prevent death. Because we know a fetal growth-restricted fetus has a high risk of intrauterine death, and even in the newborn period has a lot of risks. So the first surveillance tool is the umbilical artery Doppler. The umbilical Doppler then becomes the primary surveillance tool, and if you see, there is a systolic peak and a diastolic peak, and the ratios are S by D, resistive index, pulsatility index, and as the gestational age progresses, your RI and PI values reduce. So when you see this patient, though the fetus is growth restricted, you find that the umbilical artery PI is on the 50th centile. That means there is continuous forward flow and low resistance. Okay, so it's still under stress but not distressed. So what do we do next? We call the patient again. You may find one of these patterns. You may find normal pattern, which I just showed. You may find increased resistance, where slowly the diastolic flow is reducing. Then absent end diastolic flow, there is no flow during diastole, or then there is reversal. These become indications for enhanced fetal surveillance or delivery. So going back to our patient, when we did a surveillance, we found that the growth was low. There was resistance there was end diastolic flow present. That means this fetus is hypoxemic but not acidemic. So what do? We could repeat a Doppler after 1 week and would delay the delivery until 37 weeks, but with careful intrapartum monitoring if she goes till 37 weeks. But if you call her and you find absent end diastolic flow, that means the PI value has gone way above the 95th centile. That's the absent end-diastolic flow. That means 60 to 70% of the trophoblastic villi are no more supplying oxygen and nutrition to the fetus. This fetus is at increased risk for cerebral hemorrhage, anemia and hypoglycemia, and even for death. So what does the fetus do? When there is absent end-diastolic flow and very little blood supply is coming, the blood flow is redistributed to vital organs like the heart, the brain and the adrenals, and there is reduced blood supply to the muscles and to the kidneys. So you would expect oligohydramnios, that means reduction in the fluid around the baby, and what is called redistribution of blood flow. So at this stage, we need to admit, give steroids, do close monitoring and delay the delivery till 34 weeks, and do deliver this woman in an optimal NICU care. The next stage, this is the redistribution, where we find that there is the RI values have come down. That means there is redistribution of the blood because there is vasodilatation. Then the next step would be a change in the venous flow. When ultimately the myocardium also suffers damage, you will then have reversal in the venous flow, and this fetus is at a very, very high risk of intrauterine hypoxia and also acidemia. So an abnormal venous Doppler means that the fetus is at very, very grave risk, is acidotic and may die in utero. So if you see the sequence of deteriorating fetal status, first there is reduced fetal growth, then cessation, then reduced amniotic fluid, ultimately non-reactive NST, and the way you monitor is first you do the umbilical artery, then you do the middle cerebral, there is an abnormal middle cerebral ratio, and ultimately there is an abnormal venous Doppler. And these Doppler changes precede the abnormal NSTs. Right. So if you see overall how Doppler predicts IUD, if there are late Doppler changes, that means umbilical venous pulsations and reverse flow, the mortality is very high, whereas if there are early Doppler changes, the mortality is very low. So how does Doppler help in the surveillance of the fetus? It plays a role in surveillance and thus preventing perinatal death. It detects changes in the feto-maternal and uteroplacental circulations. It helps to monitor the fetal well-being. So if there is good forward flow, I can continue the pregnancy. You can take timely action, as in when there is absent end-diastolic, plan the treatment and prevent adverse outcome in high-risk pregnancies. Now, coming to another case, a 27-year-old second gravida, admitted at 30 weeks with pain in the legs, that is a deep vein thrombosis, undergoes a thrombectomy and a GA. Morning you heard her, the continuous intrapartum monitoring, how it affects the fetus. She received heparin, Maxel, thiopental, succinylcholine, and an intrapartum CTG revealed absent baseline variability. The senior obstetrician immediately performed an LSCS and had a preterm fetus of 30 weeks, not steroid covered, with an Apgar 0 to 6. The fetus was intubated. What went wrong here? We misinterpreted the CTG and the effects of gestational age on the fetus. So that's how we need to know about what is CTG, how do we interpret it, why do we need to evaluate it. When we interpret a fetal heart rate tracing, we have to be very clear about the background clinical condition, the gestational age of the fetus, what are the prior results of fetal assessment, what is the medication she's received, what are the maternal medical conditions, and what is the fetal condition. Because our aim is to detect fetal hypoxia, prevent acidemia and cell damage, thus reduce hypoxia-induced intrapartum perinatal mortality. In labor, this fetus is at repetitive stress because the umbilical arteries and the uterine arteries undergo strangulation. The uterine contractions do interrupt the uterine blood flow, and there is a transient period of hypoxemia. So if this fetus is chronically hypoxic, you add an acute distress to it, this fetus is certainly going to have acidemia and death. So this is the sequence. Hypoxia, that means reduced oxygen, accumulation of carbon dioxide, respiratory acidosis, intestinal paralysis are increased, there's relaxation of anal sphincter, meconium, and pneumonia and death. So here is another case example where she's a second gravida, para 1, live 1, gestational age 38 weeks. She's induced for intrahepatic cholestasis with a drug that is a prostaglandin, misoprostol. What happens? First of all, we do an electronic fetal monitoring, which is an assessment which records the heart rate, fetal movements, and uterine contractions. There is a standard terminology. I can't just say the CTG is good, bad, not too good, not too bad. We are all expected to use a uniform terminology because, again, if you see root cause analysis of 47 fetal deaths, 72% was due to poor team communication. 34% was inadequate fetal monitoring. So unless we are all trained to interpret CTGs and know what is a good CTG, what is a bad CTG, what is an abnormal CTG, we are all going to speak different languages. So the terminology that is used is Dr. C. Bravado, and DR means determining risk, contractions, baseline rate, variability, accelerations, decelerations, and an overall assessment, opinion, and the line of action. So each CTG that you see, you should be able to give this terminology and then give your opinion as to is this abnormal, normal. So coming to the contractions, the lower traces the contraction. You see that it returns to the baseline, and again there's a contraction. So because this period is very, very essential to have that blood supply replenished again, because during this contraction, the fetus is going to be starved for oxygen. Now, coming to another, the CTGs, we said baseline. So this forms the baseline. That means a period where there are no accelerations and decelerations. This fluctuations and the variations in the RR interval is the baseline variability. The periodic changes are accelerations, there are no decelerations. So this is a normal trace. So a normal trace, to say it's normal, should have a baseline fetal heart rate between 110 to 160. The beat to beat variability, which is the most important, should be at least more than 5. There should be accelerations and there should be no decelerations. When all 4 parameters are normal, this is a very, very reassuring sign. That means there is no hypoxia, there is normal fetal acid-base status, and the tracings may be followed as per your protocols, and no specific action is required. Now, what is baseline variability? These fluctuations in the baseline heart rate are the baseline variability, and these indicate that there is an intact nervous system and the fetus has a normal neurological modulation. When does the variability reduce? Most of the anesthetist drugs, opioids, alcohol, anesthesia, or when there's not an intact CNS like an anencephaly, a premature baby, less than 30 weeks, will not have a good baseline variability. Apart from these abnormal conditions, there is just a status of fetal sleep, which is a normal physiological state. You may not have any baseline variability. You can almost see a straight line. Now, in active labor, you may see periodic changes, especially if you start syntosnon or the patient is in labor. You can see the contractions have increased. You can see these coupling. So if there are 5 contractions in 10 minutes, averaged over a 30-minute window, you call it tachysystole. They may or may not be associated with decelerations. So normally you expect only about 3 contractions in 10 minutes, each lasting for 30 to 60 seconds. So what are the risks this woman has? Intrahepatic cholestasis, 38 weeks, and with this CTG, there is tachysystole. What we found is there were more than 5 contractions and there is abnormal fetal heart rate. So this fetus is definitely under stress, probably compensating. So what are the other periodic changes that we have seen? This is called an early deceleration. This is a mirror of the contraction. This is generally because of head compression and again not associated with hypoxia or acidosis. Now, there is a category 1, we said all 4 parameters normal. The second category is a pattern where both 1 and 3 are not. There is an indeterminate category. Again, this is not predictive of abnormal fetal acid-base status, but requires evaluation. Especially these patterns are generally seen when you give a top-up epidural or you have given sedation in the form of morphine, pethidine. You may find category 2 tracing. What we need to do is do a continued surveillance and re-evaluation. What is important is do not ignore this type 2. They may become type 1 or they may change to type 3. Category 3 is certainly abnormal and bad. This needs something to be done. And this is one pattern where is a regular sine wave. This is a sinusoidal pattern, or you found a decreased baseline variability with unprovoked decelerations, with absolutely no baseline variability. This is certainly a very, very ominous tracing. And the other ominous part is this late decelerations. We spoke of early deceleration where the drop in the fetal heart matched the contraction. In the late deceleration, the deceleration starts at the peak of the contraction, drops down, the nadar is well beyond the peak of the uterine contraction. There is recovery after the uterine contraction has passed off. And this is critical. This indicates uteroplacental insufficiency or some degree of hypoxia. And depending on what stage she is, we need to take some action. So what, out of all these 4 features, if you see the baseline heart rate, baseline variability, and decelerations, which is the feature which is very, very predictive of asphyxia? This is a nice large study where they have seen the predictive value of electronic fetal monitoring for intrapreterm fetal hypoxia, and they have found that absent or minimal baseline variability with late and prolonged decelerations is highly predictive of hypoxia, and you need to do some supplemental tests or deliver this woman because there's a high degree of suspicion of hypoxia, or if it's false positive, you certainly need some additional test. So what are the supplementary tests you can do? You can do a scalp pH where you measure the lactate levels and the base excess. The normal pH is more than 7.2. Pre-acidotic is 7.2 to 7.25, and less than 7.2 is indicative of significant acidosis. The base excess, if it's between 12 to 16, most of these infants are having encephalopathy or respiratory complications. So more than 16, almost 40% of these infants have newborn encephalopathy. So what can we do when we find these tracings? Can we resuscitate the fetus inside? Do we need to deliver this fetus? Yes, we certainly know in this trace, the fetal heart has gone shh. So does this fetus, is it just about to die? Does it have poor fetal oxygenation? Is it poor uteroplacental perfusion? Is the umbilical cord compressed? What do we do? We need to deliver or do some intrapartum resuscitation. Again, fentanyl is one drug which we commonly use. It's a drug which is certainly known to cause these bradycardia changes. Less than 30 minutes, you can see usually within the next 8 to 15 minutes it can cause bradycardia, and this may be associated with hypertonus. So it certainly contracts the uterus and reduces the fetal heart rate. So you have to think of some way of resuscitating this fetus. So the first and foremost would be, if she's on a syntocinon flow, stop it and then go ahead with intrapartum or intrauterine resuscitation. So what do we mean by the term intrauterine resuscitation? You have to know all the history, the maternal background, what is the fetal reserve, what has caused this distress. Is this the drug? Is this the stage of labor? Is it the maternal condition, hypotension? Is it the syntocinon? And then, is this fetus, do you feel that this fetus is going to be resuscitated? Is it likely to be resuscitated? There is a rule of 3 for prolonged bradycardia, the bradycardia that I showed, 3, 6, 9, 12 and 15 minute rule. You have to assess, exclude abruption, cord prolapse, scar rupture. So this takes about 3 minutes where you're thinking and deciding what to do. Then, the next 3 minutes, you have to examine the clinical
Ma'am,
situation.
actually, allotted time is up.
Okay, I've actually finished.
Okay.
So I would talk about SPOILT and M, syntosnan off, position, oxygen, IV infusion, low blood pressure, tocolysis. You can give terbutaline to these fetuses to improve the fetal heart rate tracing. Thank you. I would conclude. 1 second, sorry. Yeah. Decision delivery interval, and probably conclude by saying, yes, these fetuses need to be delivered very soon. And if she has an epidural, you top up the epidural or give general anesthesia so that you deliver this fetus very soon. To conclude, a Doppler velocimetry is an indicator of chronic uteroplacental insufficiency. CTG tells you about the acute conditions. Bradycardia with reduced baseline variability are ominous, and intrauterine resuscitation does help buy time to recover the fetus so that you deliver the fetus in an optimal time and an optimal condition. Thank you, and sorry for exceeding the time. Sorry.